Hangman's fracture, also known as traumatic spondylolisthesis of the axis. As an introduction to Hangman's fracture, we should know that acute fractures of cervical spine number 2 represent around 20% of cervical spine fractures, and neurologic injury is also uncommon and occurs in less than 10% of cases, and this was also the rule in craniocervical junction injuries. Types of C2 fractures are odontoid fractures, Hangman fractures, and miscellaneous C2 fractures. Here we can see the anatomy of the C2 fracture, the C2 vertebra, the axis, and we can see here the pedicle and the green lines and the pars interarticularis, which is our concern and important concern in C2 in Hangman's fractures, here in the red lines. It is bilateral fracture through the pars interarticularis or the isthmus of the pedicle of C2. Here in CT we can see the fracture pars bilateral, and here we can see a diagram that mimics the Hangman's fracture. It is usually stable fracture and the deficits are rare, or neurological deficit is rare. 90% of cases or more than 90% heal with immobilization only. And also operative fusion is rarely needed. All these details will be mentioned. This is the Hangman, just to know the relation of the name. It is the Hangman, and it was thought that the Hangman fractures are mainly caused by this type of trauma, but as we see here, the most common presentation of Hangman fractures usually with axial loading and not distraction as in hanging. This plus hyperextension. So axial loading plus hyperextension, and it is not common to be axial loading with distraction. Pediatrics. Hangman's fracture is rare in children less than 8 years old, where the forces tend to fracture the incompletely fused odontoid. In pediatrics, pseudo-subluxation is an important differential diagnosis. The pediatric axis has 5 ossification centers. The two halves of the odontoid fuse together in the midline at 7 months of development, and at birth there are 4 primary ossification centers in addition to a secondary ossification center that appears and called os terminal, appears between 3 and 6 years of age and fuses with the dens by 12 years. So dens is late in fusion and ossification. The other ossification centers, the primary ossification centers, are odontoid process, vertebral body, and 2 neural arches. Odontoid process, vertebral body, and 2 neural arches with the secondary ossification center. And here is the odontoneural synchondrosis and the odontocentral synchondrosis and the neurocentral synchondrosis. And here we can see the coronal section in CT that shows the same. Pseudo-subluxation occurs in children between the second and third cervical vertebra, and up to the age of 10 years, flexion and extension occurs at the second and third, is centered at C2-3 level, and after that it moves to C4 or C5 after the age of 10. C2 normally moves forward on C3 up to 2 to 3 millimeters in pediatrics, and this is not pathology and considered as pseudo-subluxation should be considered. Classification is very important and it has a long history and started long time ago, but the modern classification for Hangman's fractures, we should know some important names. The first is Effendi, and after that Levine modification of Effendi's classification. After that Edwards and others did some modifications with Levine. After Effendi classification, Edward and others did many modifications that ended in the final Levine and Edward classification, which is very common to use. Also, we have which is known the Francis grading and will be mentioned also, but you should know that there are numerous classification systems, and it is not wise to know all classifications, as this will complicate the knowledge related to the management. Any classification system will not cover all types of fractures. As you know, the trauma is bizarre. The system of Effendi et al. As modified by Levine and others as Edward is widely used in grading adult Hangman's fracture. It is not applicable to pediatrics, and as we mentioned, the odontoid fractures are more common to be fractured than Hangman's presentation in children. Angulation is measured as the angle between the inferior end plate of C2 and C3 and the anterior subluxation of C2 on C3 more than 3 millimeters. It's a surrogate marker for C2-3 disc disruption, which can be evaluated more directly with cervical MRI. Here we can see the 5 grades of Levine and Edward, the modified Effendi's classification. It is 5 types. Also Francis grading is 5 types. So we have 5 types of Levine and Edward and 5 grades in Francis. Okay, each type here will be mentioned separately. Type 1. Vertical pars fracture, just posterior the vertebral body, and this is the classical definition of Hangman's fracture. Less than 3 millimeter subluxation, so it is simple at the beginning, and the mechanism is axial loading and extension. It is stable on flexion and extension X-rays. Neurologic deficit is rare, and the management will be mentioned later. It is conservative management. Type 1A it is the fracture lines on each side, and the A here, you should link it to a typical Hangman's fracture. Actually, type 1A is a typical Hangman's fracture. The fracture may pass through the foramen transversorium. This is very important. The fracture may pass through foramen transversorium on one side. Radiographic findings. The fracture line may not be visible on X-ray. Anterior C2 vertebral body may be subluxed 2 to 3 millimeters anteriorly on C3, and the C2 vertebral body may appear elongated. The mechanism may be hyperextension, as mentioned before, with lateral bending as the trauma is directed to the lateral foramen transversorium. Unfortunately, there is 33% incidence of paralysis. The type 2, the displacement more than 3 millimeters with possible angulation and slight compression of C3 is possible. The vertical fracture passes through the pars as a classical definition, and there is disruption of the disc, which is evidenced by subluxation more than 3 millimeters. Also, the posterior longitudinal ligament may be injured. Axial loading and extension with rebound flexion. As you see, this is type 2, and it may lead to early instability, and neurologic deficit is also rare and usually reduces with traction. We will find in the management subtypes in type 2. Type 2A is a different entity, and both type 1A and type 2A were added to Effendi classification after the original one. So type 2A, there is oblique fracture, usually anterior inferior to posterior superior, with little subluxation less than 3 millimeters. As you see here, little subluxation but excessive angulation. And here type 2A, you should link the letter A to angulation. The angle can exceed 15 degrees. Mechanism of flexion, fracture, flexion distraction. Posterior arch fails in tension. It is rare, less than 10%, it's unstable, and avoid traction as it increases angulation. Do not use traction. Causes increased angulation and widening of disc space. Type 3, it is type 2 plus bilateral C2-3 facet capsule disruption. As you see here, there is facet capsule disruption. C2 posterior arch is free and floating. Anterior longitudinal ligament may be disrupted or stripped of C3. And in the imaging, that's important to make classification of type 3, Levine and Edward. You have to find the facets of C2-3, maybe you have to find it subluxed or locked. If normal facets, it is not type 3. The mechanism is unclear and may be flexion, caused capsule disruption, followed by compression caused isthmus fracture. It is rare, neurologic deficit may occur and may be fatal. Facet dislocation usually cannot be reduced by closed reduction, and traction is contraindicated because it is dangerous. Here is the Francis grading. Francis classification is 5 grades, and we start by displacement. If displacement is less than 3.5 millimeters with angulation less than 11 degrees, it is type 1. The same displacement more than 11 degrees, it is type 2. Then if the displacement is more than 3.5 millimeters and angulation less than 11 degrees, it's type 3. The same displacement at more than 11 degrees, it's type 4. And if the displacement is more than half of the body of the C3 vertebra, as we see here, it is type 5. Here is the body of C3. If D over B is more than half, so it is type 5 Francis classification. And here is the degree as concerned by Francis, the angulation or the angle. Presentation. Neurologic deficit is rare, usually neurologically intact in more than 95% of the cases. And other presentations, and the presentations may be cervical pain, occipital neuralgia. Associated injuries may be head injury, associated cervical spine injuries, or external signs of injury to the face and head. Evaluation or imaging. Cervical CT is very important. With sagittal and coronal reconstruction, it should be done to fully assess the fracture. CT angiography, especially type 1A, as we mentioned, that foramen transversoria may be injured, and also if stroke, if the clinical figure is suggestive of stroke. Angiography and MRA may be alternatives to CT angiography. Here we can find the CT, the fracture of pars bilateral. Here we can see the sagittal. And here we can see a sample of CT angiography. And here we have multiple fractures of the cervical vertebra, including C2 and C3. And just it is a figure just to show how the filling defect can appear in the CT angiography. And here this is catheter angiography. MRI is important to check the disc and ligaments, the C2-3 disc and the ligaments, and also we can see all soft tissue elements. Here we can see the disc disruption as it is clear in the MRI. Sagittal T2. X-rays, lateral cervical spine X-rays show the fracture in 95% of cases, and it also demonstrates C2 angulation and or subluxation. Most fractures pass through the pars or the transverse foramen, and 7% go through the body of C2. The instability can be marked as anterior displacement, as we mentioned in the Francis classification. If it exceeds displacement, can usually be identified as marked anterior displacement of C2 on C3. It is unstable if the displacement exceeds 50% of AP diameter of C3 vertebral body, and we should go back to Francis grading to uh, understand well. And also excessive angulation is a sign of instability. Patients suspected of having Levine type 1 fracture, which is stable, should be assessed again under the supervision of the physician by flexion extension X-ray to rule out instability or to rule out the type 2 fracture. Here we can see how the fracture appears, the fracture line in lateral cervical spine X-ray, Hangman's fracture here. Treatment. The practice guidelines, also level 3. Hangman's fractures may initially be managed with external immobilization in most of the cases, and it is successful, and surgical stabilization should be considered in cases of severe angulation, disruption of the C2-3 disc space, or failed conservative management, which is inability to establish or maintain alignment with external immobilization. All the details will be mentioned. Stable fractures like Levine type 1 or 1A and Francis grades 1. Treat with immobilization like Aspen or Philadelphia collar, or cervicothoracic orthosis like SUMI, or is usually adequate for 3 months. Halovist may be needed in unreliable patients or combination of C1 2 fractures. Here we can see the Aspen neck collar and Philadelphia neck collar. Here we can see the SUMI without pins and the Halovist with pins. The unstable fractures, Levine type 2, reduce with gentle cervical traction. Most reduce with 30 pounds or less, with the head in slight extension, preferably in haloring under close X-ray monitoring to prevent iatrogenic hanging. Place in Halovist for 3 months. Follow patients with serial X-rays. Stabilize surgically if fracture moves, and surgical fusion will be needed of the traction and external immobilization by Halovist if failed. For some details, if type 2 fracture with displacement less than 5 or equal to 5 mm subluxation and the angulation is less than 10 degrees, once reduced by traction, apply Halovist and begin to mobilize the patient within 24 hours of injury, and verify that immobilization is adequate in the Halovist with upright lateral cervical spine X-ray. Operate if inadequate. After 8 to 12 weeks, change to Philadelphia collar or SUMI until fusion is definitely complete, usually 3 to 4 months. Type 2 fractures with more than 5 mm subluxation or more than 10 degrees of angulation, surgical fusion is preferred from the beginning because of many hazards of conservative management, and even if healing occurs, there will be residual pain, chronic pain. Alternatively, cervical traction can be maintained for about 4 weeks, and then reduction should be reassessed 1 hour after removing weight from traction, and if stable, again 24 hours after mobilizing in a halo vest. If unstable, return to traction and repeat the trial at 5 and 6 weeks. If still unstable at 6 weeks, then surgical fusion is recommended. Here's the traction. Levine Type II-A, avoid traction because it is risky due to the angulation, and use the halo vest without any traction, and it is successful in about 95% of cases. Levine Type III, avoid traction because it is also risky, and open reduction and internal fixation is recommended. MRI should be done before surgery, and after the open reduction and internal fixation, halo vest can be applied for the future or can fuse at the same time as open reduction and internal fixation. Indications for surgery, which are few patients: inability to reduce the fracture, failure of external immobilization, traumatic C2-3 disc herniation with compromise of the spinal cord, and established non-union. Hangman's fractures likely to need surgery are Levine type 2 and 3. Not all type 2. Type 3 needs a surgery, or Francis grade 2, 4, or 5, or if either anterior displacement more than 50% of the diameter of C3 vertebral body, or angulation that produces widening of either the anterior or posterior borders of the C2-3 disc space more than height of normal C3-4 disc below the level of injury. Surgical options are fusion techniques or osteosynthesis, and the fusion techniques either posterior or anterior. The posterior fusion techniques are C1, 2 posterior wiring, and wiring here because there is fracture, of limited cases because the wiring is decreasing in use, and C1, 3 fusion using lateral mesh screws, also occiput to C3 fusion in fracture C1 and C2. C1, 2 posterior wiring, and it is non-rigid fixation. It is sometimes used if C2-3 disc is intact and C2-3 joint capsules are intact and the posterior arch of C1 is intact. And this procedure unites the C1 to the posterior fracture fragment of C2, which is still linked to C3 by the facet joint, and the anterior part is linked together by the disc. And as you see here, and remember from the previous classifications, that whenever the C2-3 disc space, C2-3 disc is intact, it may come in low grades of classification, and sometimes we will not need surgery. Here is the sample of wiring in Hangman's fracture. Here is the Hangman's fracture, and here is the wiring. C1-3 fusion using lateral mass screws connected with rods, and here we can see C1-3 and bypassing C2. This is our concern, this image. Occiput to C3 fusion, as you see here, occiput bypassing C1 and C2 whenever C1 is injured and damaged together with C2. The fusion techniques anterior approach. Anterior C2-3 discectomy with fusion is optional optional anterior plating or zero profile graft or plate performed via transverse incision like that of anterior cervical discectomy, but higher levels the incision falls midway between the angle of the mandible, the angle of the jaw, and the thyroid cartilage. It is not optimal for Levine Type III that requires unlocking of the facet and cannot be performed in some short and thick necks. Here we can see the anterior approach with plating, and here we can see the Hangman's fracture. Here we can see also the Hangman's fracture, but you know the fracture here falls in the body, but we can see that spondylolisthesis of C2 over C3, so it is considered as Hangman's fracture. Osteosynthesis, screw placement from the posterior approach through the C2 pedicle across the fractured fragment. It is not recommended for established non-union. The fracture must be reduced before the screw holes are drilled. The entry point is similar to C2 pedicle screws, and the length of the screw is 30 to 35 millimeter. And here we can see the osteosynthesis here, the transpedicular fixation of the fracture directly. Thank you.